Welcome to this podcast, which is about heavy menstrual bleeding for patients, so heavy periods. If you want further information, you can access my podcasts at Paula Podcast on Twitter, on YouTube, and on my Patreon page. There are matching podcasts for healthcare professionals which might give you further information if you're interested, but for today, I'd like to keep things fairly simple. Heavy periods are really common. They affect 1 in 5 women, and it's very difficult because you don't know what anybody else is experiencing. But if you're finding that your periods are causing you problems, you feel they're too heavy, then they are, and there are lots of treatments available. So it's really important that you go and see your GP because this is a gradual thing that can build up. So if you bleed heavily every month, eventually your blood count will become low. You will accommodate for that, and therefore you might not notice until it's so low that you're breathless, exhausted, and unable to look after your family. So let's start first of all with causes of heavy periods. The commonest cause is called dysfunctional bleeding, and it's due to your hormones. So if you have investigations like ultrasound, nothing will be found. And there's no point in measuring your hormones because these change all the time. What happens to some women is that they don't release an egg. And if that happens, then the levels of estrogen are not opposed by another hormone called progesterone, and they can become too thick with the lining of your womb shedding chaotically. For you, what that means is that you might bleed throughout the month, or your periods might become longer and heavier and more painful. And none of these things need to be put up with. If you're over the age of 40 and your bleeding pattern changes or you start bleeding between your periods, then it's really, really important that you see somebody because investigations are required. The least likely cause is cancer of the womb, but it's the thing that we don't want to miss. And the reason that we don't want to miss it is because for most women, this is a treatable cancer. And it doesn't come straight away like cancer. There are preliminary stages that would be with which you'd be eligible for less invasive treatments. And we sometimes use Marina or a similar intrauterine system to manage heavy bleeding and also the precursor to cancer, which is called endometrial hyperplasia. NICE guidelines were drawn up. The guideline is called NICE Guideline 88. It used to be called NICE Guideline 44, but it was reviewed, and there is a section within this guideline for patients which make it very clear what treatment options should be available to you. The first line treatment is Marina or a similar intrauterine system with 52 milligrams of a hormone called levonorgestrel, which will keep the lining of your womb thin. It doesn't stop ovulation, so it won't make you feel menopausal, although heavy periods are very common in the menopause transition. So that's before your periods stop altogether, but a time when you might be experiencing menopausal symptoms. If you either don't want a Mirena or you can't have one for a reason such as fibroids, then you would be eligible for the next level of treatment, which includes often the combined pill or the mini pill or progestogens on their own. And the next stage of treatment is injected progestogens, and also drugs called GnRH analogues, which stop your cycle altogether. If none of these things work, and all of these could be delivered by your GP, then you move on to the next stage, which is endometrial ablation. That means that the lining of your womb is destroyed, so there's nothing to bleed from. And the last resort is hysterectomy. So back to the causes, because we stopped at the commonest cause, which is dysfunctional uterine bleeding. There are structural causes, but these are less common. And these include polyps, which are fleshy tags, a bit like skin tags that you might have on your neck or your thigh, but they're inside your womb, and they increase the surface area from which you bleed. Then there is a condition called adenomyosis, which means that little bits of the lining of the womb become embedded in the muscle, and that makes the uterus or the womb bulkier, and again there is a bigger surface area to bleed from. Then we have fibroids, and the medical term for those is leiomyoma. And finally, malignancy. So there is a classification called the Palm-Cohen classification, P for polyps, A for adenomyosis, L for leiomyomas, and M for malignancy, which is cancer. The other side to the classification is the non-structural causes, and these include bleeding disorders. They're called coagulopathy, ovulatory dysfunction, which is the hormonal cause, inflammation, endometrial issues, and then there's a category for we don't actually know why you have a problem, but you obviously have the problem. So with regards to investigation, the first line investigation will either be ultrasound, and it's usually a transvaginal ultrasound with a probe that goes inside your vagina. It's not painful, but it gives a good idea of the lining of the womb and the ovaries, and if there are any smaller fibroids. This can be combined with a contrast like saline, which is salty water, or a local anaesthetic jelly, which improves the ability to tell whether there are polyps or what kind of fibroid you might have, because there are types that cause problems, and they tend to be in the lining of your womb. And then there are other types on the outside of your womb which would not be associated with heavy periods, but they might cause pressure on your bladder, so they may cause problems, but in a different way. Then we have hysteroscopy. That's a camera, a very thin camera, which goes inside your womb and has the ability for whoever's doing the procedure to see directly the lining of your womb, and to be able then to take a biopsy called an endometrial biopsy from any area which looks abnormal. Sometimes we use abdominal ultrasound if fibroids are large. And I want to show you now, just to finish off, what a Marina looks like. Now, this is Marina's baby sister, Jade S, but it's exactly the same, except that it's got less hormones. So I'm only using it because it's the same insertion mechanism, and it's what I've got. This is an example of a womb. So it's very, very tiny, and I think that women think it's going to be gigantic because, of course, if you have had children, then they grew inside, but it stretches to accommodate a full-term pregnancy. But as far as the Marina insertion is concerned, this is a really skinny introducer tube going into a tiny little cavity, and it will, for some women, feel crampy. But for most women, particularly women who've had children, and I think we have to understand that women who are experiencing heavy bleeding are often at the extremes of reproductive life, so they may be close to their periods starting when they're younger, or close to their periods finishing when they're older. And then the other group are women who've got polycystic ovarian syndrome, and we have to be careful about those women because although they bleed infrequently, when they do it can be really heavy and they have an increased risk of endometrial cancer. So something like an intrauterine system makes a big difference. I think that some women decline this option because they've heard bad stories, and nobody goes around shouting about things that have been not as painful as they thought. For many women, having a Marina in means they don't bleed. And like it says on my my Twitter picture, there's nothing good about bleeding. It's not good for you, and it's not normal. In the past, women were either pregnant or they were breastfeeding and not bleeding, but they died earlier. So you're not doing yourselves any favours by not getting treatment. So this is how it goes in. This is your cervix here at the bottom. Really skinny tube. There's a releasing mechanism here. You can see the arms coming out, up to the top, down to the bottom and out. And that's how quick and easy it is. And if you find it's more difficult for you, then whoever is doing the procedure can use local anaesthetic jelly or an injection, which doesn't feel like an injection anywhere else. It's very like the injection the dentist would use. So, to finish off, heavy periods are very common. They can cause a lot of problems. They can make you depressed. They can make you less productive, and you don't have to suffer. There are lots and lots of treatments which don't involve necessarily horrible investigations, and for most women, the causes are simple and common. Thank you for listening, and I hope you'll join us for the next episode of At Paula Podcast.